Hello, everyone. Welcome to Teddy Talks, a podcast created by UCL Paediatric Society, where medicine meets mischief and we discuss all things pediatrics from teddies to training pathways. Each episode will be breaking down the wild world of pet pediatrics through stories from the wards, chats with doctors who have loads of experience in the field, and have honest conversations about the future of pediatrics. Whether you're a medical student, aspiring medic, or just here for the baby giggles and interesting cases, you're in the right place. We hope you're just as excited as we are. I'm Yameena, one of your co-hosts, and I'm a second year medical student. Unfortunately, Letitia, my other co-host, isn't with us today, but we'll be seeing her in our next episode. In our last episode, we had Dr. Naomi Jones on the show, and we discussed all things neonates in a really touching, thought-provoking episode. We discussed the interaction between medical ethics and law, decision-making, and the fragility of both patient and parent in the NICU. We were really able to see models that we speak about in the academic setting, things like the biopsychosocial model applied into the everyday life of a pediatrician. But today we'll be shifting our focus to a side of pediatrics that isn't discussed as much as we would like to be, and that is palliative pediatrics. So to help us explore this topic, we're delighted to welcome Dr. Dilini Rajapakse to the show. Dilini is a consultant in pediatric palliative medicine at Great Ormond Street Hospital and is an alumna of UCL Medical School, graduating in the class of 1995. She also holds a master's degree in clinical neuroscience from UCL, as well as higher training qualifications in pediatric palliative medicine and pain medicine from the University of Wales and the University of Edinburgh. From 2007, Dr. Rajapakse has been working across both palliative medicine and chronic pain teams at Great Ormond Street. Her main focus has been on improving how we manage pain and symptoms for children, and she's published widely in this area. Alongside her clinical work, she's heavily involved in teaching at UCL Medical School, the RCPCH, and GOSH itself. What really drives her is finding ways to improve the quality of care for children and young people with life-limiting conditions, whilst also inspiring and supporting the next generation of paediatricians through education and mentorship. So, Dilini, welcome to the show.
Thank you for having me. It's nice to be here.
Thank you so much for being here. So we'll get started with just breaking down what your specialty is, because I think there's a lot of misconceptions in palliative medicine as a whole, but specifically pediatric palliative medicine. So I think there is this trend across medical students, the general public, and beyond as to what palliative care means. And I think there is this kind of preconception that palliative care in general means that we're tackling with loss of life a lot, and it involves a lot of death. And I think that can be a very discouraging conversation to have, and it discourages a lot of people from, seeking further within the specialty. But actually, those who I've spoke to within the specialty often speak about how palliative care is all about life and giving life to these patients. And so do you share this view, and can you elaborate a bit more on your own personal definition of what palliative medicine is?
Yes, of course. So you're absolutely right. I think there is a common misconception that palliative care is synonymous with end-of-life care. And that's both in children and also in the adult world. And it sort of makes it a taboo subject immediately when you hear the words palliative care. End-of-life care is an absolutely a very important part of palliative care, but it's only part of it. And as you say, and even more so in children, as compared to the adult world, palliative care is about maintaining good quality life where there is incurability of the underlying disease process or life-threatening complications along the way. And the word to palliate actually means to walk alongside. So the idea is that we should be palliating symptoms everywhere in medicine. We shouldn't be leaving symptoms uncontrolled. But the actual, how that plays out in palliative care in a situation where you may not be able to modify or cure the disease to a great extent, it is about actually treating the symptom as an entity on its own, rather than what we usually do when someone presents with a symptom like pain. We try to look for the cause of it and we tackle the cause. And we also should be treating the end result as well. which is the pain. And we do that at the same time. As the cause becomes less and less amenable to treatment or reversibility, then what we do in palliative care, symptom management, is about treating that end point. So it is walking alongside symptoms and disease processes.
I think that is such a beautiful way to think about it as well. I think especially in the sense that the doctor is the person walking alongside, and we'll talk about how, like specifically, the relationship between the doctor and the patient is a bit more. It's a bit different in palliative care, especially because it's a longer term thing. We'll talk about that a bit later on, but I really like that viewpoint on that. This question kind of branches off of that first one. So we've kind of broken down the fact that palliative care is more than end of life care. But if we go back to that kind of misconception that some people have, I think when we add pediatrics onto palliative medicine, that concept, we often come across this idea that people find it even more disheartening, because we're witnessing, or we think we're witnessing, a lot of passing of, young children and young people. So I was wondering, why did you choose to practice palliative care for children as compared to adults? And if general peds was probably what preceded your palliative choice, what settled that decision that this is what I want to do?
Absolutely. I think it's different for different people who end up in paediatric palliative care. For me, I was training as a general paediatrician, so I knew from medical school and my attachments at medical school that I wanted to do paediatrics. And so way back when I was training, joined a paediatric training program as a junior doctor, and you go and you get your postgraduate exams. And then you apply for a resident doctor or a registrar at that time, registrar training program. And at that time, I think even when I was more junior and doing my rotation as what we used to call a senior house officer stage, which was just after house officer jobs or foundation training jobs, I was always drawn to the aspect of paediatrics that was more about managing chronic illness. The problem solving and the tasks, the task orientation that was around chronic disease. So things like developmental pediatrics, neurodegenerative and neurodevelopmental pediatrics, neurodisability really was something that always really interested me. So without even knowing it at that time, because palliative care wasn't an established subspecialty of pediatrics then, I was already being drawn to children who were living with incurable conditions, whether that was neurometabolic conditions or syndromes like trisomy 13, trisomy 18, whether it was cerebral palsy, which is non-progressive brain insults. I was already interested in the symptoms, like symptoms and complications that they had, like pain, like agitation, like dyspnea and seizures. And that then led me into wanting to know more about sort of neuroscience. And that's how I did a master's in clinical neuroscience at again, back to UCL for that. And that really interested me in pediatric neuropathology. And I suppose there was a time when I wondered whether I wanted to subspecialize in pediatric neurology. But after my sort of initial registrar jobs, I was also interested in cancer care. And so I really enjoyed working. I worked in a busy pediatric oncology shared care unit at Basildon Hospital and then at Southend Hospital during my registrar training. And I was really fascinated by the supportive care, which is again symptom care in children who have oncology and hematology and malignant hematology diagnoses. And also that time when with children with brain tumours, for example, would have as much salvage or as much chemotherapy and other modes of treatment as possible, but then they went on a non-curative pathway. There were no more curative treatment options. How those decisions happened and how the families were supported and when they went into a more palliative phase of their treatment. So that really interested me, and I went and did subspecialty training at the Royal Marsden in paediatric oncology then. Then when I came back, I thought that's what I wanted to do. I wanted to be a general paediatrician with a special interest in neurodisability and oncology. But I had an amazing mentor in my penultimate year at the Royal London Hospital called Vic Larcher, was my boss there, and he was a clinical ethicist and a paediatrician, and he wrote the initial RCPCH guidelines for the ethical framework for understanding and making decisions about changing the goals of care in intensive care situations. So he was the original author of that document for the RCPCH back in the 90s. And it's been revised since then by him and other colleagues in my specialty. So he said, look, why don't you go and do this palliative care job at Great Ormond Street Hospital under Dr. Anne Goldman, who was the person who really started this subspecialty at GOSH. And so, but again, it was just supposed to be a job that would support the oncology training that I'd had and make me a more rounded paediatrician that knew all about those aspects of care. But during my time in my last registrar job at GOSH in the palliative care team, I just really realised that this puts together everything that I want to do. I want to work with children with chronic disease. I hadn't appreciated that actually a lot of those children are life-limited children where there's no cure to their disease. It combined my interest in neurology, it combined my interest in oncology, and it also, because it was a job where I saw children in hospital at GOSH, but I also had the privilege of being able to see children in other partner hospitals and at home and work with the children's hospice sector that the UK is so famous for. It was really good to be able to be a paediatrician, seeing children where they are comfortable rather than always in hospital. And this idea of being able to do virtual ward rounds and scramble a virtual team together around a patient wherever they were was really appealing to me. And so I did think about at that time, can I really go the rest of my career without fixing children, without curing them? Which is obviously not something I got into medicine for in the first place. That wasn't my intention at all. But then I really thought, well, actually, I am improving quality of life, and I'm improving the quality of life for children when the situation is taken out of all of our hands, when there is no more that medicine can do for the child. It's still a really important place to be able to alleviate distressing symptoms, then to be able to look after the family as a whole, to see the family in bereavement care, see them go on living alongside their grief was something that I don't think you can ever say that it's not rewarding in that it doesn't deal out happiness, this specialty. But what it does do, it gives you an immense sense of using your scientific knowledge to be able to look at pharmacology in a particular way, to look at pathology in a particular way, to look at how drugs used elsewhere in medicine can be manipulated to do what you want it to do in this situation. It helps. You think about ethics, you think about psychology, you think about social context. Every family is different. Every child, even if they have the same pathology and they're exactly the same age, it plays out differently. The whole situation is so unique, and there's so much choice that families and patients have that it's really rewarding. It is really rewarding to be able to support a child and family through this. And we're learning more and more all the time. So that's how I got where I am, and I've been doing it for 20 years.
And it's so amazing to think. I think especially because, as you said, pediatric palliative medicine is such a young specialty, but the way you described it, it's so all-encompassing. It's almost surprising to realize how young it is. And it's also, I think the kind of quick definition really doesn't do the specialty justice in that sense. I think it was really lovely how you touched on the idea of the career being rewarding in a different way, because I think that especially in this day and age, with how many kind of like conversations there are about entering the NHS, people moving out of the NHS. I think a lot of negativity is associated with the reward of being a doctor. But I think that fact that you mentioned that reward manifests in different ways is such an important thing to bear in mind as well. I think one thing I'm going to just one reflection, because that was a lot. I had lots of thoughts as you were speaking. Was I really valued. I think your kind of conversation about chronic pain was so refreshing, in the sense that I think, particularly now in the post-COVID world, in a world where we're developing technology, for example, exponentially. I think one of the kind of hot topics in the NHS is waiting times, waiting lists. There's this kind of like sense that medicine and healthcare has to be rapid, and the health, being a member of a healthcare team is working rapidly. So I think, again, it's a really refreshing perspective to have this kind of long-term plan and these long-term aims. And we forget sometimes that healthcare isn't just a temporary thing for some people. Some people, it's a permanent kind of integrated part of their routine, just like any other routine is for any other person. So I think some really valuable reflections there. Okay, so I think that we've spoken a bit more about what palliative peds is, how it's far from what it seems initially. I think we're going to move on to what life is like within your field. I mean, in the past, you've discussed that there are kind of two core concepts within palliative pediatrics, which is advanced care planning, or the ACP, and symptom management. Could you elaborate on the role of these, what they are, and how you use them within your role as a palliative care pediatrician?
Sure, yes. So symptom management is all about, you'd think that everybody has symptoms. So symptom management should be there throughout medicine. Absolutely. You can't leave somebody in pain without treating it, whatever the cause of it or whatever is driving it underneath. But in palliative care, the idea of symptom management is to think about what the actual symptom is and also what might be driving it. But then to actually also contextualize the symptom so that you're able to manage it in almost in a very individual way rather than in a protocolized way. So I'll give you an example of that. If you've got a child, as we sometimes have, or a young person, say a 14-year-old who's got metastatic osteosarcoma, and so that is a bone tumor that young people, adolescents, often get I mean, it's all very rare, but it's one that we see. And so these bone tumours present initially often in the long bones, so either in the femur or in the humerus or somewhere else. And it sometimes just presents as a swelling. And they go to their GP or they go to their local hospital and they have an X-ray which shows that they have, sadly, what looks like a bone growth. And there is a set cancer pathway, as there is across medicine in adults and in children, for what happens next. And so they have their osteosarcoma or their bone tumour diagnosed. Now, where that malignancy can spread to, can metastasize to, includes the chest. So you can get lung metastases with an osteosarcoma. And there is a combination of chemotherapy, radiotherapy, and surgery as part of treatment in a cancer protocol for osteosarcoma. But sadly, some children do not get better from it, and they either relapse or they may relapse more than once. And at some point, there are no curative treatment options. And even in the case of chemotherapy or radiotherapy, those are only to palliate symptoms. So they're not to cure the disease entirely. And our team will then be involved in part of the multidisciplinary team that works around this young person. And if a child like that has lung metastases at the time that we may become involved, they may still be going to school, they may still be going out with their friends, having fun with their family, they may still be, as often happens in this age group, they may still be working hard for GCSEs, for example. So they're living the life still that an adolescent lives, albeit with this disease process as part of their lives. And so at the point that we might see them, if they're doing all of those things and carrying on living their lives, if they present with a symptom like dyspnea or distressing breathlessness,
Yeah.
And at that point, we're not talking about end of life care. We're talking about being able to alleviate that symptom so that they can continue to live in as highly functional way as possible and as good quality of life as possible. So it may be appropriate at that point to treat dyspnea by admitting them to hospital, doing a chest x-ray, finding a pleural effusion there and draining it with a chest drain. So that seems like a lot of intervention when you know that the underlying driver for that pleural effusion is not a curable thing. But it's the right treatment, or may well be the right treatment, in terms of the balance of risks and benefits for that particular individual at that point in their disease pathway. So bringing them into hospital, getting the cardiothoracic team around, getting a chest drain put in, alleviating their breathlessness and their dyspnea, and then sending them home is probably the right thing to do, or certainly should be part of the mix of possible options for treating that symptom. However, fast forward a few months down the line, and this child may then have much more widespread metastases. They may have more bone disease, more bone marrow disease. They may be anemic at this point. They may be quite anorexic and cachectic, and they may well be virtually bedbound, but certainly much nearer to the end of their life than they were previously. In that scenario, if they present with dyspnea from their lung metastases, if you weigh the risks and benefits of getting them into hospital, doing a chest x-ray, finding a pleural effusion and putting a chest drain in, that might be too big a risk for very little benefit. So same child, same disease, same situation, but the context is very, very different. And so how you manage that same symptom of dyspnea is very different at that point. And at that point, the right management, or the management that's in the child's best interest then, would be a full explanation and maybe medical management within their home. So with drugs like low dose Oromorph or low dose opioid and benzodiazepines like midazolam may be the right thing to address the symptom and make them feel better, but a very different management of dyspnea than putting a chest drain in, which might be too big a risk for not enough benefit.
Exactly. Yeah. I think we were speaking actually on our previous episode on a similar concept. So Dr. Naomi Jones is a neonatologist, and she was talking about sometimes, we have this mentality as doctors or as healthcare professionals that we need to do everything we can. And she spoke about how she kind of shifted her mindset from doing everything she can to everything she can do to help, because sometimes, as you've clearly described, less is more. And we'll talk about those kind of conversations a bit later, but now that we're on this kind of pain management pathway, which is something I'm really interested in hearing more about, I think that chronic pain is a hugely underspoken about topic. I think it is also quite stigmatized, especially towards certain groups, namely young people, women, and people of color. And I think sometimes for people within those kind of groups, chronic pain is often undermined. So my question is, how do you tackle that kind of social aspect? So for the lack of a better word, how do you tackle that stigma around chronic pain when dealing with conversations with patients and, their wider support system?
Yeah, absolutely. It's a really important point. So my area of chronic pain practice is actually separate to the palliative care work that I do. So in chronic pain, just as you say, it is a huge problem. It's a huge socioeconomic problem actually in adults, and it's very well documented in that way. In young people, it was much less well documented, and actually it's not as prevalent a problem in adolescents as it is in adults. And there is also evidence that there is a better prognosis if in the adolescent age group when you for chronic pain, but it is something that was probably under recognized previously. And it is a problem. Most of what my patients tell me when they come in to see us at the Gosh clinic, so Gosh is one of two nationally commissioned paediatric chronic pain services in the UK. The other one is at Bath, and it's what we hear time and time again is that young people feel disbelieved because they've gone through a situation where it's not like having a broken leg. You haven't got crutches and a big cast on your leg, which tells everybody immediately you've done something to yourself, so no wonder you're in pain. Chronic pain is really a silent villain, if you like, because people aren't screaming in pain, even though the pain they're feeling may be a 10 out of 10, because they're managing it. But it takes a real toll on someone to manage their pain. So lots of people come and tell us, nobody believes me, or they think it's in my head and they think there's something psychologically wrong with me. So it's not real pain, it's just I'm weak and I can't get myself out of this and I need to pull myself together and get on with things. So the burden of chronic pain means people can't go to school, so their school attendance drops. It means they can't maintain their social relationships. If you drop out of school as an adolescent, you miss out. You miss out not just on your academic education, but you miss out on the social aspect of it. You miss out on friendship groups. You are ostracized as being the one who's a little bit weird. You're the one who can't do PE. You're the one who's weak because you feel sorry for yourself. In every lesson, you have to put your hand up and leave the classroom. And because they don't have anything externally to show for it, then they're not believed. And so that's a real problem. And people come to us with very low mood, very anxious, sometimes with a lot of comorbidity, psychological comorbidity. And the two then feed into each other. The lower you feel in yourself, then the worse the pain feels. And that any one of us can relate to that.
Yeah.
And so chronic pain is something that people also don't realize, that there is what we call a biopsychosocial aspect of looking at chronic pain. And this is backed up by many, many decades of research. So we know that there is a biological phenomenon, a psychological phenomenon, and a social context phenomenon. So there are your mood and your thoughts contribute at a neurological level to how your pain is manifest. So whether the amplification, whether your pain volume is set at high, or whether you're able to reduce the volume of the pain that you perceive, is dictated by things like that, but also about what's going on in your life. So periods of stress, like your GCSEs coming up, or you're being bullied at school. Or there is a particular teacher who really doesn't understand what is happening in your life, and you have that teacher on a Friday. That will all turn up the volume of your pain when that is happening. And we know that. We know that biopsychosocial model is underpinned by things like functional MRIs, where we used to have this idea that there is one pathway. You injure yourself and there is a neuronal pathway from the peripheral nerves to your spinal cord, and then you've got messaging up to one part of your brain, which is the pain bit. Unfortunately, pain is much more complicated than that. And we know from fMRI imaging that people with chronic pain, areas of their brain light up very differently compared to those people who are not in chronic pain. And some of those areas are linked to things like your memory. They're linked to things like attachment. They're linked to things like your mood. They're linked to things like coping mechanisms. So it's interesting how there is neuronal networks that are involved in and evolve when people are in chronic pain states, where those connections, that matrix doesn't exist if you're not in chronic pain. So it's all biology, it's all neurobiology. There isn't physical pain versus psychological pain. Every pain is biopsychosocial.
Exactly. I think also adding on to that, with particularly with young children, they're still in this kind of stage of life where we're learning kind of the idea of action and consequence. So I can imagine there's like a layer of blame to that. So for example, parents will tell children, don't have ice cream before dinner or you will get full. And then that's a consequence of your action there. Or don't go near the oven or you'll get hurt. And that kind of, I guess, for patients who are young and who are still processing and see like a negative, a negative experience as being a consequence of an action. I think there might be so many, like a lot of distress generated with kind of self-perception and blame in that sense as well, especially when so many injuries, like falling from bikes and running too fast, or crossing the road without looking both ways, they're both associated with a kind of injury or a consequence in a sense. Then that's how we kind of learn about the world around us and how we assess risk. Have you ever had any experience with like kind of dealing with conversations about this isn't your fault? It's not your fault that you're in a position where you're experiencing this, and you kind of have to navigate a different conversation that's no longer action and consequence, or a consequence, but simply just a consequence. I know it's a bit of a weirdly phrased one there, but
No, you're absolutely right. I think also what you're alluding to is this idea that people get very fixed with a biomedical model
yes.
of health. So symptoms like pain, people forget that actually there is neurobiology of pain, and just like any other aspect of your body that can go wrong, so can purely the neurobiology of pain that can go wrong without anything making it or driving it going wrong. So people often, and parents particularly, get stuck in this biomedical, what we call the biomedical model, which is that they still feel that there is some disease process that's keeping their child in pain that we just haven't found yet. And so they're subjecting their children to more and more investigations. They're looking for arthritis, they're looking for a genetic problem, they're looking for a bone problem, they're looking for a brain problem. They can't dissociate themselves from the idea that just because all of the investigations to date are reassuringly normal, their child is still in pain, and they can't understand that actually it's the pain biology for which there is no scan that will show that. There is just the symptom, the chronic pain, that tells us that the neurobiology of pain in your body is what is not working properly. And that can happen spontaneously. People can just literally, it just happens to them. So as you say, this consequence, it's not a consequence, it just happens spontaneously. And we can't pinpoint who it will happen to and who it doesn't happen to yet. Or it could happen after another pathology. So, for example, someone could have a fractured wrist and that then heals, but the pain doesn't stop. So normally when whatever is broken gets better, the pain should stop when healing has finished. And that's a period of time that takes, on average, about 3 months, which is why we say we don't diagnose chronic pain until after 3 months of having it. And people will come and say, but the orthopedic surgeon still, just keeps x-raying and saying that there's no problem with the wrist anymore. It's completely healed and it's healed perfectly and he doesn't need to operate. But there must be something wrong because the pain hasn't stopped yet. That isn't the bones in the wrist that are wrong. That is the neurobiology of pain that is causing the persistent pain. And that's the bit that's going wrong. And treating that is not doing more surgery on the wrist. Treating that is treating the underlying biopsychosocial aspect of what chronic pain is. And just like, because it's biopsychosocial, it means you have to treat the biological, you have to treat the psychological, and you have to treat the social context. And so that all is part of why the assessment of oh, excuse me, sorry. You might have to edit that. The assessment of chronic pain is, we have a multidisciplinary clinic. So there is a doctor, there is a clinical nurse specialist, there's a psychologist, and there is a physiotherapist there. And all of those people do the assessment. And we then have a period of time where we do what's called psychological formulation. So the patient is not in the room, and we talk about the entire history and what might be contributing to this chronic pain state. So yes, there might be some physical pathology persisting, like in post-operative pain, there might be some scar sensitivity there. which needs a neuropathic agent or it needs a nerve block. But we also then think about this 13-year-old is experiencing their parents' divorce at this time, or they're being bullied at school. So that's a social context. They appear to be in very low mood and they're self-harming. So we bring in all of those aspects and we do what's called a formulation, where we see the relative importance of each of those aspects of the history and examination. And we then make a bespoke biopsychosocial pain management plan, which might not have much of medications in it, if that's not the main driver, but it might need some psychological input into it, because this person is quite traumatized or catastrophizing or ruminating, which is helping to maintain this chronic pain state. They might need a graded timetable at school because it's too much stress for them to go 5 days a week, 9 o'clock till 4 o'clock. They might need to go in for some lessons. They might need a physiotherapy plan because they are biomechanically weak, because they haven't been doing much exercise, so their muscles are weak, and that is also contributing to a persistent pain state. So it's a very tailored model based on a multidisciplinary assessment, and that's how we use that biopsychosocial formulation to come up with a tailored management plan for them.
Exactly. I think what might be the most nerve-wracking in those situations is that uncertainty, because I think we are taught, for medics, non-medics, that there is that I think we speak about medicine and healthcare in that kind of biomedical sense. I think maybe that push towards biopsychosocial is definitely something we can do for the next generations of healthcare education, even within the home, between parent and child. But that uncertainty and the kind of shift from something that we thought we knew and we thought we understood, to something that we've not really, if a person who hasn't had any exposure to kind of chronic pain and what that experience is like, it's a complete kind of shift of what we previously assumed was true as well, in that sense. So a really interesting conversation to have there about the future. But now I think this is going to be a bit of a shift of hopefully a bit of a nicer, more personal question for you. So I think one of the nicest aspects of pediatric palliative care, and something that I really took from your talk at Gosh Summer School, was that your work with the patient and the family is a long time relationship of sorts, and you will get involved with the family and you'll be a real source of information and comfort for them during what can be a really distressing and really scary time. Are there any other gems of sorts that really makes this specialty amazing for you?
Oh yeah, as I said before, the fact that I'm, the bulk of my work is outside of a hospital setting. Often I think that was the bit that really attracted me, and I didn't know it existed. I didn't know doctors could do that. I always thought of doctors either in GP surgeries or in hospitals before. And a little bit when I did community paediatrics, I sort of got a sense of children are, they're in a family unit and they're in a wider community there. And so the idea of being able to go and see the patient where the patient is a real privilege and a really valuable part of palliative care. I've just come back from a home visit now. And seen a really happy young man at home, and who's just recovering from being in hospital, and it's just really great to see how much better he is at home, and you don't often see that when you're doing acute paediatrics. The other thing I think about palliative care is that you get to work with NHS and non-statutory organisations. There are a lot of people out there. I mean, the biggest one is the children's hospice sector. So there are about 46, maybe more, children's hospices now up and down the UK. The first one was Helen and Douglas House Hospice in Oxford that was opened in the mid-80s. And we've just gone, I think we are really privileged in the UK to have such a vibrant and hardworking children's hospice sector. And they are all charity-based. So they work within their local communities, fundraising and rely predominantly on that. Some hospices have up to about 20 to 30% NHS funding, and they have worked hard to make those contracts with the NHS. But they're a real lifeline to families with children with chronic illnesses. Unlike the adult hospice sector, which also do amazing work, children's hospices are about living with life-limiting conditions. And the focus is on supporting children to live their best lives.
Yeah.
Whatever is going on with them. And so they provide much needed respite for families. So children can go there and stay there while their families, maybe while their parents focus on other siblings in the family. There is daycare there. So during the summer holidays or during the holidays, they can go there and they can dip in and out. They have many therapies that we sadly are just not available in the NHS. Things like music therapy, yoga therapy, art therapy. They have toy libraries there. They have mother and baby sessions. It's really interesting how, you know, when you have a baby, there are so many community things that you can go to. Your local library will do singing groups and all the rest of it, and mother and baby groups. But when you have a child who has special needs from the time they're born, it's really difficult to access those groups. And why should that be? So children's hospices open up the kind of usual things for the preschoolers within the hospice sector. They have coffee mornings for parents. They have dads' days where it's difficult sometimes for dads to share their feelings about having children with special needs or children who've got chronic illnesses. So, and they have really important sibling groups as well. So growing up with your life-limited brother or sister, if you're going to mainstream school, is a really difficult type of growing up to have. You often witness things that other children don't witness. You feel like your parents' attention is taken away from you and directed towards your disabled sibling. You might sadly lose your sibling in childhood, and you may not be much more than a child yourself. And so you witness a lot of things, and you might also be partly a young carer for that child. You might have more than one brother or sister with the same condition. And you start to feel a bit guilty that you haven't got it. And so there are so many things that other family members go through, not just the patient. And children's hospices are really involved in supporting all of that. So it's really great to work with partners like that. There are other charities all that support paediatric services. We also get to work with community nursing teams. We get to work with other acute paediatric wards and centres. So I have a huge network of friends I can call for various things in the paediatric world. So I guess, that's one of the really rewarding parts of working in this subspecialty. You just get to see a lot more of life. I get to see children in schools, so I get to see special education needs teachers. You really get to be a part of, it's an area of paediatrics where you get to be a part of children's health, not just hospital, not just about, it's not just about health, but about their whole lives. So that's really interesting. And like you said, you get to know the child and the family for a long time. And even after, even if the child doesn't survive their childhood, you still get to be a part of the family's life afterwards, helping them during their bereavement.
Exactly. I think it's so amazing because, there's that phrase that it takes a village to raise a child, but then that child grows up, but the village grows with them. So it's all encompassing again, that element there. This is a bit more of a personal question, so feel free to answer at your discretion. But I think sometimes, I mean, I've already felt it, but I've just only completed my first year of medical school. But I think sometimes, us trainees, medics, doctors, we often see ourselves as the educator or the teacher. So we explain the plans, we explain the procedures to the patient, or even in your case with your experience in medical education, to students as well. Has there been a scenario where a patient has taught you a lesson that stuck with you? And would you mind sharing it with us?
Oh my goodness, there's been so many scenarios of patients teaching me lessons. Yes, I think I think there are often very humbling lessons that patients and families teach. I think one of the important ones is that you don't know everything. So, like you say, that there are these situations where, it happens particularly as you go further in your medical career. I always think there comes a time when it's often when you're senior registrar, or, you're almost a consultant, where you think you're invincible. You really do. You have seen it all before. It's where that you've got the pinnacle of knowledge. You know everything about everything, and you know the latest guidelines. You know the latest evidence base for everything that you're doing, and you have yet to be humbled. So you are invincible at that point. And it doesn't last long. It doesn't last long, because the way humans are, you may see what happens most frequently, but you haven't seen everything. And in that bell curve, there are always people at the two extremes. So even when you know how to treat something, and I'm thinking things like, you may have seen the chickenpox rash a million times, but there will come a point where you wrongly diagnose it, and a chickenpox rash turns out to be something very different, and sadly sometimes it might be something much more threatening. So there is that situation as well. But I think certainly the way I've been humbled is really in palliative care, is by seeing how families cope with losing a child. Because I'm a mum, and I cannot even allow myself to put myself in that situation. And you'll find a lot of people in my specialty are like that. They can take themselves up to a certain point of empathy, but it's just too overwhelming to go the next step and actually put yourself in that situation, or wonder what it might be like to be in that situation. And that, I think, seeing families go through that, and I still don't know, and I'm honest with them. I tell them I don't, because people often say, well, what would you do, doctor? And I have to be honest and say, I'm not in your position, and it doesn't matter how many times I've seen it or witnessed it. I can't, and don't underestimate how awful your situation is, because I have never been in that situation, and it is infinitely worse being in it. I can tell them how I've seen other families get through it. Nobody ever gets over losing their child. They learn to live with it, and they learn to, as time goes on, the way grief works is that you continue your relationship with the person that's been lost, but you form a new relationship with the void that they leave behind. That's what their legacy is. They've made an impact on the world, and they've made an impact on people, and that doesn't stop just because they're not there anymore. It'll continue until the bereaved person is no longer alive. But that relationship that person left behind continues with their lost loved one, is what grief and acceptance is. It's a lifelong journey of reforming a relationship which is irreversibly now changed to not one with the living person. And that's what grief is. And I don't know how parents do that, because nobody ever expects to outlive their children. And yet some people do. So telling them that I can see people get through it, and I can talk to you about how I've been told they do that. But I can't tell you how to do this, because I don't know. That's you have to put your hands up and say, I don't know. And people value honesty when you say that. I can tell you about how to treat pain. I can tell you about how to do this, and I can tell you how to your decision making, if there is a decision to be made.
Mm-hmm.
But a lot of the time, some families in those situations, they feel like they're being asked to make a decision when actually they're not. You know, and this goes back to advanced care planning that you were asking me about.
Mm-hmm.
You know, changing the goals of care or
Mm-hmm.
changing the goals of intensive care from sometimes it might be involve withholding or withdrawing life sustaining treatment.
Mm-hmm.
It's not a parental decision to make. Nobody's asking them,
Mm-hmm.
is it time to lose your child? So
Mm-hmm.
that's a medical decision to be made.
Mm-hmm.
What our role is to reconcile parents to what is inevitable.
Yeah,
and it's to bring them to that place so that they feel like they've done everything possible.
Mm-hmm.
You know, they've turned over every stone that's going to result in their child continuing their life, but it's no longer possible.
Mm-hmm.
Our role is to get them to that place. It's not to ask them to do it.
Mm-hmm. I think that actually really nicely links to our next question. In our last episode, we were talking about a real trend that came up. I think it comes up a lot, specifically in pediatric healthcare as a whole, which is this idea of communication and how communication and consent and all of these things are a bit different in pediatrics compared to adult healthcare. I think I'm quite intrigued about, we've spoken about how, you know, the impact on the parent and decision making in the parent's view, but I was really interested in how, when appropriate, do you approach those kind of breaking bad news kind of conversations with the pediatric patient themselves?
Yeah, that's a really important area of pediatrics. I think we um, you know, we tend to, as pediatricians, we're always told that we're very paternalistic. We, you know, we safeguard we gatekeep our patients, and we, you know, with all the right intentions, and we don't allow them to make difficult decisions. And maybe that's right in some way, but the legal consenting framework is very clear in the UK, or in England certainly, in the sense that up to the age of 16, the consent needs to be taken. The legal consent needs to come from a parent. Between 16 and 18, it should come. You should go to the patient first, and over 18, obviously you're an adult, and it's always the patient. Now, what we are seeing more and more, and this idea of Fraser or Gillick competence, which is a framework, it's very similar to the adult mental capacity assessment. It's basically saying, do you understand what the procedure is? Do you understand what you're consenting to? Can you remember when you're told about the risks and benefits? Can you recall them? Are you able to understand consequences of your decision making? Those are the main areas that you're testing, if you like, to in Gillick competence and or Fraser competence, depending what you're looking at. So even though that, you know, at 16 your parents should give legal consent, to be honest, nowadays most 14-year-olds know what's going on. But their parents may not realise it, and they may not be able to talk to them about it. But anyone who's got a phone knows how to use it and can get information, as much information as they want, or not want, and they will be in charge of that. So that idea of competence, you have to make a judgment as to what your patient is likely, you know, how much they will understand and how much they want to take part in decision making. The other thing about children's development is that in palliative care in particular, or when it comes to having serious illness, the developmental stages of understanding mortality is a psychological development that takes place throughout childhood. So if you think about it, the average 4-year-old doesn't really understand the concept of the permanence of death. So most 4-year-olds, if they're told their grandma has died, they may look sad, or they may not even look sad. because they don't understand that that means grandma is never coming back
Yeah.
again. Say, they might go, oh, well, okay, they might,
Mm.
and parents might get very upset,
Yeah.
they didn't seem to react, but that's
Mhm.
because they don't really understand what death means. And they might,
Yeah.
in 3 weeks' time, they might come back and still say, well, when's grandma coming round? And parents will think, well, didn't they understand it, or don't they remember what we said? It's not that. They may have seen grandma at her funeral, but they didn't understand what the permanence of death is.
Yeah.
That comes a bit later, when you're about 7 or 8. And the imagination, sort of imagery around death also changes. A preschooler will think about what you see on cartoons as death, so being coshed on the head with a hammer, and then Bugs Bunny gets up and starts running again. So it's a very violent idea about death. So you have to be careful about how you explain death to a 4-year-old, because their idea of it is firstly impermanent, and secondly quite violent. But they're not frightened of the violence. As time goes on, you understand the permanence of death, but you also lack the coping ability and the psychological stress of that. So, that might make things like stressful things happen to you, like you start bedwetting again, for example, or other things like that. So that starts to happen. So that developmental understanding takes time. And that's in the usual sense of developmental psychological development. Children who have experienced ill health, they are, if anything, more expert, because they have been exposed to ward care. They have been exposed to illness. So a child who's been treated for leukemia will understand a lot more about illness and life-threatening, and also about healthcare, much more than the average 6-year-old, for example, who's never been to hospital for anything. And they might have witnessed people being very sick, say in the bed opposite them. They might even, sadly, have witnessed someone dying. They might be aware of it. And so they might have experienced a friend who they had treatment with now no longer being there, and have had that explained to them. So they can have pockets of extreme maturity whilst also being only 6 in other ways. So that idea of involving children into their decision making is something we sometimes have to educate parents around, because parents might be going around thinking that their 14-year-old doesn't know that their metastatic osteosarcoma is now life-limiting and they are going to die. And they'll be saying, well, they know they've got cancer, but they don't know they're dying. And the child, though, may know full well what's going on, because they understand, well, I don't seem to be having any more treatment, but I feel sicker. So something's not right with that equation. They might have got the information they need to get from the internet. But they too, and we call this what's called mutual pretense. The parent doesn't tell the child for fear of hurting them, and the child doesn't tell the parent what they know for fear of hurting them. And families live in this this kind of equilibrium
cycle,
of silence, and that can be both. It can be a real barrier to moving forward, and for addressing anxiety, addressing stress, addressing symptoms, because that can ramp up things like pain immensely, that anxiety and fear. But it might also be a protective mechanism. And some families live in that right up until their child dies. So I think our role is to sense what is going on in that information sharing between our patient, who is the child, and their family, and work out whether it's appropriate and how much it's appropriate to involve the child in the decision making. Between 16 and 18, we always have to ask the child whether they want to be the ones who we speak to in preference. So that is how the kind of legal framework of consent has changed in more recent times. It is not ethical to exclude the child
Mm.
if they're 16 to 18 in the first instance. You can't talk to parents in preference of the child. You have to approach the child first. And it might be that the 16-year-old says, thank you, but no thank you, I'd rather you speak to my parent. That's fine, but you have to give them the opportunity.
The choice
and
first.
I would say that usually from about 13, 14 onwards, we try to get the patient's permission to discuss with the parents. It's inferred in the consultation.
Yeah.
So if we think that the patient is competent enough to receive the information, we try to give them a voice to be able to say, thank you, but no thank you. Please have the conversations with my parent, or can they be in the same room at the same time? Or, no, I'd like you to talk to me, and can you talk to my parents separately?
Yeah, and that comes back to that idea of the social context again, because everything from understanding the barriers to understanding the patient preference, it all is again all encompassing in that sense. So now we're going to shift again, but the next two questions are quite linked in a sense. So we've spoken, I mean, earlier on in the episode, we spoke about the kind of beginnings of palliative care medicine. But a real hot topic at the moment is the NHS 10-year plan, particularly with its emphasis on the movement from hospital to community, from analog to digital, and from sickness to prevention. I was wondering what your perspective on how this plan will impact and evolve the field of paediatric palliative care.
Definitely.
Yeah.
I would say palliative care is actually your, if you like, it's your poster specialty for the 10-year plan. The 10-year plan was almost written for palliative care, because palliative care is virtually doing it already. And it should certainly be, there are areas of practice in palliative care which is best practice for this 10-year plan. So the idea of care in the community, or this being able to transfer easily from various healthcare settings and non-statutory settings. So being able to move seamlessly from primary care and community in the home through to a secondary care hospital, through community therapy services, through to a tertiary centre, and move around in that setting seamlessly is exactly what palliative care has been doing and does. That's what we need in all of healthcare, absolutely. That is exactly, this idea of having a virtual health, social and education care team around a patient, all talking to each other, even though they're in different sectors, all being able to input into this individual's healthcare package, making sure that the chronic aspect is dealt with, but also being able to step up or ramp up the care when there are periods of acute intercurrent illness, etc., and being able to transfer that patient from different healthcare settings seamlessly is exactly what palliative care do. We involve ambulance services, we involve GPs, we involve community nursing services, we involve second-tier acute paediatric ward-based care, and we involve tertiary and quaternary care. And we do that, we make a bespoke plan around the patient. So that is definitely what we should be doing. And the cost of that kind of healthcare isn't great. What costs money is leaving people in hospital beds for longer than they need to be in them. The cost of palliative care is mainly salaries. There's very little extra that is not already part of the healthcare system. So it's that coordination is what palliative care have already developed an expertise in. The next thing, from moving from analog to digital, there are lots and lots of palliative care elements of good practice in palliative care, from things like using your smartphone to track your symptoms. So there is quite a lot of work being done in digitizing healthcare that can be used for palliative care. Someone could be sat at home with their symptoms and be able to directly contact the clinical nurse specialist in palliative care at GOSH to be able to say, I'm sitting in maths and I've got the pain in my leg has escalated and it's now a 8 out of 10. and they can just send all of that information in real time into a palliative care service. We can then map that to their symptom profile and then be able to generate, well, take this dose of Oromorph for it. So that kind of symptom tracking, there's a lot of research going on in the States and in Canada. Certainly with pain research, things like the My Pain Toolkit is a real-time symptom tracker, and things like that have been really useful. And for children, I know this from projects that I've heard about at various pain conferences and things, is that you can, what they call gamification. So you can gamify this healthcare data, so it makes it more interesting for children because they're already gaming anyway. You could turn their diabetes control into something that they can easily, that you can gamify and turn into something that we can get information, relevant information that can drive management planning from it. So yes.
Perfect. I think the final point is practically the aim of palliative care is that kind of walking along step by step concept that we spoke about earlier. So our final question, time has absolutely flown, is I want to ask, what advice do you have for medical students interested in your field? One doctor I spoke to says the best piece of advice you can give for this question is who shouldn't pursue your career. So I'm going to test that out, but if you want to rephrase it a different way, please feel free to do so.
Who shouldn't pursue palliative care?
Yes.
I think it's, I see what you're saying, but it's, I think only the person knows what they're best suited for. But I would say, palliative care is, as I say, it's in children's palliative care. First of all, you've got to have a love of paediatrics. You need to be able to know, what's going on in paediatrics in order to be able to then know how to palliate someone. So, for example, you need to know what the APLS guidelines are for treating status epilepticus in a child. You've got to know the algorithm for disease modification treatment before you can deviate from that algorithm to palliate the symptom. Does that make sense? So you have to know what the standard is in order to be able to say, well, what are the risks and benefits from that standard? Fine. Well, that bit is not appropriate in this care setting for this child on a palliative pathway. So I'm going to do something, I'm going to have something that is similar, but not the same, or similar, but doesn't have to be delivered in hospital, for example. So you need to have a love of paediatrics for sure. And I would say you definitely need to want to imagine healthcare as not just something that happens in a hospital. You've got to understand how healthcare plays out in the context of someone's life, because what you're aiming to do is improve quality of life for as long as possible. And so you've got to have an understanding of how you measure or how you determine how you assess someone's quality of life. So you've got to be able to work with other settings. So you've got to really have a love for interdisciplinary healthcare. So, understand other people's roles and how your role fits in with theirs. So nursing, psychology, physio, OT, teachers, social workers, and all of that. And that's got to be something that you enjoy doing. And you've got to be quite good at problem solving, because you have to think outside the box. It's not always, the protocolized management. It is taking the protocol, understanding the fundamentals and principles that are at play in that protocol, and then be able to tailor it to what this particular child needs effectively. And I would say I worry about using this word resilience, because it makes it sound as though we're all made of Teflon and you can beat us up as much as you like. That's not the case. I think you've got to have the humility to understand when you're running on empty, because you're not able to give anything to anyone if you're empty. So understanding that you're not, having the humility to understand that you take on suffering, and there is a certain amount of that you witness. Having the humility and being humble enough to realize that and be insightful about when you're running on empty and know when to go and fill up and how you do that. So you have to be able to focus on your self-care more so, I guess more so than anywhere else in pediatrics or healthcare. You're no good to anyone if you're burnt out.
Yeah.
Least of all to yourself.
Exactly. I think that point on humility is such an important one, specifically for doctors. I think, especially on the journey to getting to that position of consultant, I feel like a lot of us are very much praised and coddled and are constantly told about what an amazing job you're doing. I think, especially from, a cultural perspective, I come from a culture where doctors are treated like gods and we are, put on this pedestal. I think one of the most amazing things about the NHS, it's a double-sided coin, but I think it is just such a human practice. I think that all the interactions I have, and I hope that the interactions I have in the future as well are, we really, I think, especially in the last few years, we really have seen that kind of shift of patient and doctor as equal. We're kind of really breaking down that kind of power inequality, which is really exciting and it's really encouraging to see from the patient perspective. Unfortunately, that's all the time that we have today. I just want to thank Dr. Dilini Rajapakse for joining us. So many takeaways from that episode. Oh my goodness, I'm going to have a long think of this after this one, especially considering how different dealing with life-limiting conditions is, but also how similar it is and how all-encompassing it is to like many different subspecialties within pediatrics, but in wider health as well. So thank you so much for joining us. And to our listeners, if you are a med student interested in pediatric palliative medicine or just want to be better at supporting your younger patients, we really hope this episode gave you some food for thought, and we'd love to hear your thought via Spotify or Instagram if you liked what you heard. Make sure you're following our new Instagram at teddytalks.peds for updates on when episodes will be released. Please rate this episode on Spotify and share. Thank you so much for listening to Teddy Talks. We'll see you next time.